Welcome back to Translation Oncology Insights. I'm Rittika, and today we are exploring next generation CAR T cell engineering strategies, specifically which are designed for solid tumor challenges. Rejoining me today is Dr. Sneha Pathak. Dr. Pathak, can we discuss about traditional CARs and how they were designed for liquid tumors? How are second and third generations of CARs being fundamentally redesigned for solid tumor biology?
Thank you, Ritika. Yes, for sure. So the evolution of CARs, it reflects our deepened understanding of solid tumor immunobiology. The first generation CARs actually provided only primary activation signals sufficient for eliminating isolated leukemic cells, but they were inadequate for the sustained activation required in immunosuppressive solid tumor environments. But the second and third generation cars, they incorporate multiple co-stimulatory domains like CD28, 41BV, OX40, and they provide a sustained proliferative and survival signals necessary for persistent anti-tumor activity in the hostile microenvironments. So this is it.
Right. So let's start by examining armored cars specifically. How do cytokine secreting cars address microenvironmental immunosuppression?
So the armored cars, they represent a paradigm shift from passive to active microenvironment modification. The interleukin 12 secreting cars, they simultaneously activate CAR T cells through autocrine signaling while recruiting and activating endogenous immune cells like NK cells, macrophage, and dendritic cells, and thus creating a coordinated immune responses. Now, interleukin 12 also promotes a Th1 differentiation and inhibits a regulatory T cell function, thus fundamentally altering the immune balance within the tumors. On the other hand, interleukin 15 armored car address a different challenge, persistent and memory formation. So interleukin 15 promotes central memory T cell differentiation and prevents activation-induced cell death, crucial for sustained anti-tumor immunity in solid tumors, where antigen clearance is gradual rather than rapid.
So basically, can we talk about what about more sophisticated cytokine engineering approaches?
We are seeing elegant solutions to cytokine toxicity concerns right now. So, membrane bound cytokines restrict activity to the immunological synapse, minimizing systemic exposure. Whereas inducible cytokine systems activated by small molecules or tumor specific conditions, they provide temporal control over cytokine release. Now, these approaches they maintain therapeutic efficacy while reducing the systemic toxicity that has limited the clinical translation of cytokine-based therapies.
Right. So let's talk about manufacturing complexity. It has indeed limited CAR-T accessibility. So how are universal CAR platforms addressing these challenges, and particularly for solid tumor applications?
Okay. So the universal CARs they decouple target recognition from T cell activation through modular designs. The most advanced approach uses biotin and streptavidin systems where CARs recognize streptavidin and biotinylated antibodies provide target specificity. This enables targeting multiple antigens with single CAR-T products, crucial for addressing solid tumor heterogeneity. Now, allogenic approaches present different opportunities. They like CRISPR-edited universal donor T cells with TCR and HLA class 1 disruption avoid graft versus host disease while providing off-the-shelf availability. For tumors, this addresses the challenge of manufacturing autologous products from patients with heavily pretreated immunocompromised T cell populations.
Right. So what are the regulatory and manufacturing implications? Can you go deeper into that?
Yes. So allogenic CARs could transform the economic model of cellular therapy. Instead of patient-specific manufacturing with 2 to 3 week production timelines, allogenic products enable immediate treatment initiation, which is very crucial for rapidly progressing solid tumors. Manufacturing economies of scale could reduce costs from 100 to 1000 to 10,000 per treatment. However, regulatory pathways for allogenic cellular products are still evolving, I'm sorry. So safety concerns around genome editing, immunogenicity and long-term persistence currently requires extensive preclinical and clinical validation.
Right. So let's talk about and explore more into programmable CAR systems. How do Boolean logic approaches address solid tumor targeting challenges?
So logic-gated CARs, they represent the most sophisticated targeting strategies developed to date. A and D gate CARs require recognition of two antigens for activation, dramatically improving tumor specificity in solid tumors, where single antigens are often shared with normal tissues. Now, split CARs separate antigen recognition from T cell activation. One receptor recognizes antigen A, whereas another recognizes antigen B, and only simultaneous engagement triggers activation. Whereas NOT gate CARs are equally important for a solid tumor safety. These systems, they include inhibitory receptors that recognize normal tissue organs, preventing activation when normal healthy tissues are encountered. This is crucial for targeting antigens like HER2 or EGFR that are usually overexpressed in tumors but present on normal tissues as well. So this is how we are dealing with the Boolean logic approaches.
Right, right. So now let's go into another segment. Can you walk us through how these systems work on a molecular level?
Oh yes, so split cars, they utilize heterodimerization systems like rapamycin-induced FRB, KPB-B12 interaction, for instance, wherein one car component contains antigen-binding domain fused to FRB segment and another contains a signaling domain which is fused to the FKB-P12. Only when both antigens are present and rapamycin is administered do the components associate to form functional CARs. So this provides both specificity and pharmacological control over CAR T cell activation.
So let's talk about trafficking and persistence engineering. So trafficking to solid tumor represents a very, very big challenge, I suppose. So how are engineering approaches improving CAR T cell homing and persistence?
So trafficking engineering addresses the mismatch between CAR T cell homing receptors and solid tumor chemokine environments. Now, ectopic expression of appropriate chemokine receptors like CCR2 for pancreatic cancer, for instance, or CXCR1 for glioblastoma improves tumor trafficking. More sophisticated approaches involve chimeric chemokine receptors that recognize tumor-associated chemokines but signal through T cell activation pathways. Also, the persistence engineering focuses on preventing exhaustion and maintaining memory formation. Whereas the overexpression of transcription factors like FOXO1 promotes central memory differentiation, the dominant negative checkpoint receptors prevent exhaustion signaling. Some approaches involve periodic rest periods through controllable CAR systems that can be temporarily deactivated to allow T cell recovery.
So what about tissue resident memory approaches? Are they being utilized?
So, tissue resident memory engineering is particularly promising for preventing solid tumor reoccurrence. Expressing transcription factors like Hobbit or RunX3 programs CAR T cells to establish long-term residence within tumor cells rather than circulating systemically. These cells provide immediate responses to antigen reemergence and potentially preventing metastatic recurrence that occurs months or years after initial treatment.
So as we are concluding, what do you see as the most critical factor for successful clinical translation of these advanced CAR-T approaches?
The key to this success is matching engineering sophistication with clinical practicality. While we can design incredibly complex CAR systems in laboratory, clinical translation actually requires balancing efficacy with, manufacturability, safety, and regulatory feasibility. The most successful approaches will likely involve modular platforms that can be adapted for different solid tumor types rather than completely novel designs for each indication. Patient selection will be equally crucial. Unlike the hematological malignancies, where CAR T cells are often last-line therapies, solid tumor applications may require early intervention, where when patients have better performance status and less immunocompromised T cell population.
So, are there any final thoughts on the future of solid tumor CAR T therapy?
So, like we are approaching an inflection point where engineering solutions are mature enough to address fundamental biological barriers. Coming in the next decade, in the coming decade, we will see CAR T becoming a very viable option for solid tumors. But success will require integrated approaches combining advanced engineering, but with rational combination therapies, optimized clinical implementation strategies. This is what I think.
Yeah. Thank you, Dr. Pathak, for this insightful analysis. So, next episode, we'll examine CAR T manufacturing challenges and scalability considerations for tumor applications.